Okay, so the objectives really, I wanted to review the current outcomes just briefly of the kidney transplants, and then identify risk factor for allograft failure and the patient morbidity and mortality. And then we can discuss about the management of the medical complications following kidney transplant. So this is just like statement that we are all aware of, that successful kidney transplant, right, improves quality of life and reduces mortality risk for most patients when compared to maintenance dialysis. So it's an ultimate treatment for patients with kidney failure if they are deemed suitable for a kidney transplant. So it's not for everybody. So this is one of the hallmark articles published in New England Journal of Medicine. I don't want to count years, 22 years ago, that show that there is a significantly reduction of the relative risk of death after the kidney transplant. However, you guys see that initially, right, in the early post-transplant period, the risk is higher, and this is just related to surgery. That's why we try to be careful to evaluate if someone would be strong enough to go through surgery at all, and then the post-surgical complications and so. So the after about like 8 months or so, then they started to really enjoy the benefit of the kidney transplant. So we want them to get to that point, to be able to enjoy a normal life that free of dialysis. So what do we do? How do we care of these patients? So it requires teamwork, as this picture show, that it's not just the transplant nephrologist, or it's just not just the like local nephrologist. It's combination, right? And from internists, primary care providers, transplant center, and the local nephrologist who is seeing the patients. Because theoretically, the transplant center cannot follow all these patients like frequently forever, because we exponentially transplanted more patients. And you would see, like here at Georgetown, we transplant 300 patients a year. So, in 10 years, we would have 3,000 patients, and we just can't see these patients every 3 months, year in and out. So you guys are like a major, very important part of taking care of these patients. So the goals really is to, when I have a transplant patient, I want the patient to the transplant to survive, but it doesn't matter if the transplant is working if the patient is not with us. So there are things that can lead to allograft failure, and there are things that can lead to the patient's mortality, even with the functioning graft. That's what we don't want to happen. So this is not Jeopardy game, but and we're not going to try to do that today. But there are a lot of aspects, and I'm going to try to get through some of these that I think would be helpful for you guys. So let's just start with immunosuppression, because I think that is probably kind of the core of what you guys need to know when you take care of these patients. So the maintenance therapy, which is going to be the main thing that I want to talk about today, because the induction therapy is just not something that you guys are going to be part of. It's good to know, but maintenance therapy is what the patient continues to take long-term, indefinitely, or as long as the allograft is still functioning. Right, so it can include steroid, calcineurin inhibitors, which is the major component of the immunosuppression, anti-metabolites, mTOR inhibitors, and the co-stimulatory blockade agent. So 70% are on steroid, maybe a little less nowadays, because a lot of centers are going towards a steroid withdrawal, including our center. The main protocol is a steroid-free protocol, which is not for all the patients. And 90% of the transplant centers, patients are on tacrolimus and mycophenolate. All right, so let's just take a look at this case. Right, so 3 years after deceased donor kidney transplant, a 50-year-old guy with ESRD from diabetes, diagnosed with tuberculosis. And then he was started on treatment with rifampin and continued his immunosuppression, including prednisone, mycophenolate, and tacrolimus. And 3 weeks later, his creatinine increases to 2 from a baseline of 0.9. And he has a protein creatinine ratio of 500 milligram per gram. UA shows just modest, just 5 to 10 white cells and really no blood. And he's asymptomatic. What is the most likely cause of AKI in this patient? So this is one of the I think most common referenced images talking about the immunosuppression and the mechanism. So it's from New England Journal of Medicine. If anyone wants to read up, it's a really good review on immunosuppression, okay? So there are 3 main signals here. Signal 1, 2, and 3. Do you guys see
We can see your cursor.
Yeah. The pointer? Okay. How about now? No.
No more. Nope.
Okay.
Just there. Yes, you got it.
So the signal 1 is to really block how the T cell is getting stimulated, right? So this is like this big guy. This is T cells. So the antigen presenting cell, and there's the antigen, and then the T cells is started to know that, okay, there's somebody else antigen here. Then only the signal 1 is not enough. So you also need co-stimulation, which is the signal 2. And then there's also the signal 3 that can inhibit the cell cycles here. So we can look at this picture. Again, I always envy if someone has photographic memory. It would be really helpful that you just look at these pictures and then you can, you remember everything about mechanism. But it's a really nice article that I recommend you guys to review. Okay, so let's talk about the caseinone inhibitors. So it worked on the signal 1, right? The first one, to inhibit T cell proliferation by inhibiting all the cytokines that are related into proliferation. The tacrolimus is binding to the tacrolimus binding protein, and the cyclosporine is binding to the cyclophilin, but it's pretty much kind of having the same effect. So in this era, we're using tacrolimus more often, much more often than cyclosporine. So you guys might see the patients who are on cyclosporine are the ones who got transplanted 40 years ago, 30 years ago. But 20 years ago, then it's probably going to be tacrolimus. Or if there was some reason that the patient cannot tolerate tacrolimus, sometimes we revert it back to using cyclosporine. So many studies are trying to compare head-to-head cyclosporine and tacrolimus, and it was kind of inconclusive, but the meta-analysis just show that tacrolimus is superior. That is associated with the improved patient mortality and decrease in the graft loss and rejection. So you can see why now, majority of the transplant centers use tacrolimus as the mainstay of immunosuppression, the maintenance immunosuppression. Okay, so cyclosporine, just an older drug. There are several forms and brands. So I just kind of, the images didn't come out like very nice here, but so the Sandimune older one, it's just kind of a generic cyclosporine. Generally, we check the trough level to correlate to monitor for toxicity and therapeutic range. Compared to the newer kind, which is modified cyclosporine or a Neoral, which has a better absorption. So theoretically, the C2 level, which is the level done after 2 hours after the patient take the medication, correlates with the area under the curve like better, but we like almost have never done it here. Or most of the centers would still use the trough level. But because it's a better absorption, Many times when you convert back and forth between these forms, we have to be careful and check the level because Sandimmune typically need a higher dose. It's more so if the patient is switched from Sandimmune to Neoral, we have to reduce the dose. Otherwise, they would end up having too high of the level. And the dose is typically, it's weight-based, 6 to 10 milligram per kilogram per day, and divided that in the twice daily dosing. The trough in the beginning after the transplant during the first year, we aim for about 200, sometimes higher. And then long term, really it's a 50 to 75. I myself, I just keep it 50 to 100 for the long-term patients who had had no rejection or complications. So tacrolimus, still calcineurin inhibitor, and I try to make it fair to show this to everyone because I have experienced this myself during the training, that the tacrolimus, do you guys know, it's color-coded, which is cool. So even with the generic form now, the 0.5 milligram, it only comes in 0.5, 1, and 5. So 0.5 is typically yellow, and then 1 milligram is white, which is the one that we use the most. And the patient would just take however they need. Like if they're on 4 milligram, they would just take 4 of the white pill. And the 5 milligram is pink. So it could be like a capsule that looks like white and yellow, white and white, and then white and pink in some of the manufacturer. My experience, like I had a patient who was on pretty high dose of the Tacro, and the pharmacy was nice, trying to be nice, and then switched the patient to 5 milligrams. Like, oh, hey, like just instead of taking like 10 of the 1 milligram, that they dispensed the 5 milligram, and then the patient ended up taking like 10 of the 5 milligrams. So the patient came in with a really, really high Tacro level. So, and it's a history taking that someone started to ask patients, like, what color was your Tacro? And then the patient said, oh, it's pink, the pink one. It's like, oh no. Then we knew that was why the level was so high. So it can be really helpful, when you take history from the patients. More recently, we have a long-acting or once-a-day dose of the tacrolimus, which is the brand name is Envarsus. There are not many patients who are on it. Some here are in the study protocol and trying to compare the benefit of using the long-acting tacrolimus. I use it in some of the patients who, have trouble remembering to take the medications twice a day, or have the levels that is really kind of fluctuating, or have a sensitive to a high level of the Tacro. So typically we check the 12-hour trough levels, and the point is that whenever you check the levels, I almost always have to ask the patient, like, what time did you take the medication the night before? Because then if it's not 12 hours, it's hard to interpret. It can be helpful sometimes that, say, the patient said, oh, like I take the medication at 8, and then they have the level drawn at noon, for example, and then the level comes low, then it's like, oh, that means that the dose is really, really low, because even it's after 12 hours, and the level was just like way low. So always ask the patient, or when you guys checked it in the hospital, some depending on the time of the morning blood draw, it might not correlate with 12 hours after the evening dose, so just be aware of that. So the target of the Tacro level is around 8 to 10 for the first several months, and then 5 to 7 after the first year, unless they have multiple infectious complications, malignancy, or have a BK viremia or BK nephropathy. We keep the level pretty low, between 3 to 5. So the side effects of calcineurin inhibitors, is, as good as this medication is that we use as a mainstay, there are many side effects, including nephrotoxicity. That's a little ironic that we use it for the kidney transplant patients. So the common the share, like the pretty similar side effects, because it's the class of the calcineurin inhibitor: nephrotoxicity, hypertension, gout, hyperkalemia, hypomagnesemia. It's about the same between cyclosporine or tacrolimus, but cyclosporine seems to have more like the cosmetic disadvantages of hirsutism, gingival hypoplasia, or hypercholesterolemia is more in cyclosporine. Tacrolimus actually have the opposite in terms of hair problem, because it could cause alopecia. There are more neurotoxicity in tacrolimus, and the tacrolimus is more toxic to the islet cell. So you see more incidence, higher incidence of post-transplant diabetes or worsening diabetes when the patient's on tacrolimus. So all of these are counsel to the patients before they get the kidney transplant, but they usually don't remember by the time that they get transplant 5, 6 years ago. And then a lot of patients came back to me and said, well, transplant gave me diabetes. And you would say, like, yeah, it's one of the side effects or complications after the transplant. Just any case, if none of you guys have seen gingival hypoplasia, it can be like pretty a bad condition too. I actually have a patient right now who wanted to switch to tacrolimus and trying to alleviate some of this gum disease. And then my favorite picture of all time is this, which is the glomeruli on drugs. So this is glomeruli on too much cyclosporine or tacrolimus. You see that this is afferent arteriole that is being so constricted. Right, so that's why when we see the calcineurin inhibitor acute toxicity, think about this picture as like the glomerulus is just glomeruli or just like not making it, right? It's so squeezed. So you see this picture like pre-renal. It's my favorite picture in the whole textbook. All right, so let's try this case. Wait, should we go back to? We can go back to the first case in a minute. So this one is the patient who's on the transplant patient on the same tacrolimus dose for 5 years. And then he started taking health food diet, over-the-counter herbal products, and then transplant center saw that his levels is just abruptly just so low to maybe even undetectable. So he's at risk for rejection. The nurse coordinator accused him of being non-compliant, but the patient insisted that he was taking the medication Cyclosporine. What is your assessment? You would think that he's just become non-compliant, and I actually do have patients who started to decided to stop taking medications because they thought, okay, like it's been long enough, then the kidneys and the bodies just get used to the kidney and just stop. So the choice A is patient's in denial. He needs immediate psych consult. You guys can kind of know that this cannot be the correct answer, right? Just test taking. Or does the patient take grapefruit extracts, a part of his herbal products and health food diet, and then that prevents absorption of his tacrolimus? Or is he taking St. John's wort, and that increases cytochrome P450 and accelerating metabolism of tacro? Or does he take creatine supplement, which we see a lot in the patients who do like strength training or a bodybuilder? And that creatine increase activity of B glycoprotein and then cause enhanced tacrolimus excretion. Or the patient takes akinesia, and that activates renal tubular excretion of tacro. Example of common drug interaction, and this is like one of the key things. I think I remember that it was on my internal medicine board exam, maybe like one question, but it's like so very important things to know, especially you guys are taking care of all these patients with multiple medical conditions. So drug interactions of the calcineurin inhibitor and other drugs or other like herbal products or food are important. So the group that is a CYP3A4 inhibitor, that means that it's going to increase your calcineurin inhibitor level. Amiodarone, ART boosting agents, it's some HIV medication, protease inhibitors, azole, this is very common, fluconazole. So if you have a GI patient who were diagnosed with, for example, H. pylori, who's prescribed clarithromycin, or have some, fungal esophagitis, needed to be on fluconazole, we have to adjust the dose of tacrolimus down because that they would have a toxicity from it. Macrolide antibiotics except azithromycin, lucky. You can still have something to use. Non-dihydropyridine calcium channel, so those are diltiazem and verapamil. So I myself don't like to put the patient on this group of medication unless they have been on for arrhythmia. Some center, so our sister hospital center, transplant program had historically has used diltiazem to increase the level of tacrolimus intentionally so the patient wouldn't have to take so many of the tacrolimus. So I'm personally am not a big fan of that, was taught not to. So I only keep it on if the patient needs it for history of cardiac arrhythmia. I did have one patient who was on diltiazem and tacrolimus, and diltiazem somehow was not refilled, and the patient didn't think more, thought, okay, like she didn't have to take it anymore. So she ended up losing the kidney transplant because she had a rejection after the tacrolimus level was too low to keep her allograft healthy. Grapefruit juice, very famous grapefruit juice. So this was on my board exam. So grapefruit juice, transplant patients were educated not to take grapefruit, not to eat grapefruit or drink grapefruit juice. The one that is the inducer, of course, would lower the calcineurin inhibitor level. So that would those example are anti-seizure medications, the rifampin, and St. John's wort. So these are the first questions patients on rifampin. So that was, some of you guys got it right, that it was a rejection because the immunosuppression level was too low. And then this one, these last questions was the patient is taking St. John's wort. Right, so that lowers the tacrolimus level. It's not because he's not compliant. All right, so that was like a big chunk of, I think, what's very important for you guys to know. Okay, so what about steroids? So steroids inhibit the NF-kappa B. It directly induce lymphopenia by causing the lymphocytes to migrate into the lymphoid organs. And immediately post-transplant, the patient would be given a high-dose methylprednisolone, like a solomatrol, 500 milligram, and then quickly taper down. So they would get 500, 250, 125, and then they may get like 75 and then just like drop to no steroid here if they are going to be in the early steroid withdrawal protocol, or they can be tapered down to 5 milligram per day. And as you guys know, side effects of the steroid, which are many. Osteoporosis, osteonecrosis, impaired wound healing, problem with the lipids, glucose intolerance, and psychopathologic effects. I did have patients who were preemptively treated for rejection with a high-dose steroid, and we were doing the biopsy, and I had a needle, the kidney biopsy needle in my hand. The patient like jumped and grabbed the needle biopsy, and we all ran out from the room because she was gonna stab the staff, including me. So it can, and you guys have seen the patients getting steroid in the hospital, that can lead to significant mood problems. Long-term low-dose steroid treatment adverse effects are actually modest, and there are multiple papers, a lot from rheumatology area, that show that being on less than 10 milligram per day long-term, they're not as significant. It's not a big deal. Then late steroid withdrawal, for someone, for example, had been on the regimen for 5 years maybe, and then started to wean off and doesn't want to be on steroid anymore, it's not recommended. It actually shows that it can increase the risk for rejection. So if we're going to do it, you have to be really, really careful in selected patients who had a very low risk of rejection. Antiproliferative agents. So the main actors of this are mycophenolate. So mycophenolate mofetil, or MMF, for CellCept, or mycophenolic acid. So the mycophenolate is the precursor of the mycophenolic acid, or myfortic. These agents inhibits the T cell proliferation, and there are, by now, there are generic, there are different forms, different doses, different strength, and I just put example here for you guys to see. CellCept 500 milligram, 250 comes in a capsule, and then there's the myfortic, which come in a different dosage and form as well. Just know that the MMF, or the CellCept, intestinal absorption can be inhibited by a number of medications. PPIs, the main guy, antacid, cholestyramine, sevelamer, and which the patients probably should not be on sevelamer after the kidney transplant. And then some oral iron, the ferrous sulfate, can inhibit the absorption. Most common side effects of this group of medications are GI side effects, as you guys may have had a lot of patients complaining of that. The older drug, and this again is azathioprine, so you may see this in the patients who have been transplanted 30 years ago when there was no CellCept. So azathioprine is purine analog and inhibits the T cell activation, as well as stop the cells to differentiate into macrophages, which is the antigen presenting cells. It can be seen we can use it in patients with severe side effects to GI side effects to CellCept or myfortic, or the patient wish to have a baby. And during the pregnancy, azathioprine is determined to be, safe for the transplant patients to maintain their immunosuppression. The main side effects are the bone marrow suppression. Another major interaction, because azathioprine turns into xanthine oxidase. So allopurinol or febuxostat will increase the azathioprine level. So you cannot use these two together. Okay, allopurinol and azathioprine are not to be used together. If you have a patient who had transplant long time ago on azathioprine and need to go on, like they have gout, for example, and you have to start allopurinol or febuxostat, then you would have to switch them to CellCept or myfortic. And then you'll be able to use allopurinol. Then mTOR inhibitors are another choices of immunosuppression. These are sirolimus or everolimus. It binds to the same FK binding protein, but inhibits the TOR instead of the calcineurin inhibitor, instead of calcineurin. And then it blocks the signal 3, if you can just think vaguely about that picture. Signal 3 will lead to cell cycle. So when you block that signal 3, then you inhibit the cytokine-dependent activation of the cell cycle. Typically, the target of the troughs is kind of like a similar to Tacro, is around 5 to 10. It has a long half-life though, so when you make the change, you might have to wait longer than tacrolimus to check the level again. And the side effects are, an example of the side effects, impaired wound healing. That's why we don't use mTOR inhibitor right away after the transplant. If someone wanted to be on, or if the transplant physicians would decided to use mTOR as the mainstay for the immunosuppression, we do it after the wound is healed. Incision is healed. It can lead to, because in impaired wound healing, it can lead to lymphocyte development, delay recovery from ATN, reduced testosterone. It can cause proteinuria, de novo proteinuria, or make the proteinuria worse. So typically, if there's proteinuria more than the protein creatinine ratio more than 1, I would stop using the mTOR inhibitor. Can lead to edema, mouth ulcers, skin lesions, hyperlipidemia is more than the calcineurin inhibitor. And then pneumonia or pneumonitis is not uncommon from the mTOR inhibitors. You guys don't see a lot because it has not really gained much of the popularity among the transplant physicians to use this as the mainstay for kidney transplant patient. And then the last of the immunosuppression is belatacept that can be used in the low immunologic risk. And what it does is it blocks the signal 2, so the co-stimulatory signal. Then without the co-stimulation, the T cells cannot proliferate. Right? So it can be used when someone really has a pretty bad calcineurin inhibitor toxicity. So it does not have the nephrotoxicity. So, you know, it kind of has a point, like a advantage here, but still has not been gaining much of the popularity. It's a once a month injection. It has to be used with other immunosuppression, so cannot be used solo as the single agent. And it has to use with it. This is the MMF, not MMR, mTOR inhibitor and steroid. And of course, improved kidney function because you can see the glomeruli are not squeezed like when they are on a calcineurin inhibitor. So there's more like perfusion going on. Increased, but it had been related to higher incidence of high-grade cellular rejection. So PTLD, particularly in the patient who's EBV seronegative and received the kidney from a seropositive patient. So that's actually a contraindication to be on belatacept. So once in a while, I have the patient who are savvy enough to read medical literature or the news and then come in and want to be on a non-kidney toxic medication. They would ask about belatacept. So it's just kind of good to hear and remember the name. Other drug interactions or synergistic toxicity that we should keep in mind that if the patient, you know, being on calcineurin inhibitor already and are on other medications that are nephrotoxic, so that certainly is not going to help. Example is aminoglycoside, amphotericin, colchicine, or NSAIDs. So NSAIDs is even going to squeeze that afferent arteriole or even like, you know, to the max. So you can see the combined or synergistic toxicity, or possible severe hyperkalemia if they are on other drugs that can lead to hyperkalemia, such as ACE, ARBs, amiloride, spironolactone, trimethoprim, part of the Bactrim. Or can be the interaction that it can increase statin levels and the risk of myotoxicity. This is from the calcineurin inhibitor. Interacting with the statin. So pravastatin is the one that has the least interaction. So put a check mark here as it's weak, but it's the one with the least interaction that you can use. Okay, so then we might not get through the whole talk, but other things I wanted to talk about is how to monitor their allograft function. So just keep in mind that after transplant, they still consider chronic kidney disease, right? And there's still going to be disease progression because that kidney that got transplanted in there, it's not frozen in time. So it will continue to, and the patients might get a 50-year-old might get a kidney from older person, or the young patient might get a kidney from parents. So that kidney is not turning into a 20-year-old, the age of the recipient. So they will continue to progress. And KDICA, which is an organization that look at the kidney disease outcome, recommend that to still regard these patients as chronic kidney disease, and any guidelines recommendations for chronic kidney disease should apply to the transplant patient as well, and maybe even more so because they have a higher risk of other complications. What do we do? Just the same thing that we monitor kidney function in non-transplant patient, check the creatinine, GFR, be aware that this is, after all, it's just one kidney, right? Except that sometimes the patient get the baby kidneys, they would get the en bloc, so they get like the whole, like both kidneys, because the kidney were small, so they get both. There is the donor recipient size mismatch sometimes. The big gentleman get the kidney from his petite wife, so that small kidney might not be enough to do an excellent job in a much bigger man. So you have to keep in mind that their ischemic injury can also lead to elevated creatinine, and then less than optimal kidneys. There's certain things, this is from the transplant specific, right? Because there's a calcium inhibitor that just keeps squeezing on that afferent arteriole. The average we have a serum creatinine, about 1.1 after the transplant. This is just kind of like rough average in everybody, which is great, but you would see that it's, as we know, that creatinine alone can be like misleading, right? So creatinine 1.1 is already, the GFR is less than 60 ml per minute. So by definition, they have chronic kidney disease. We also monitor for proteinuria, and it can be just either dipstick, protein creatinine ratio. It had been shown that the patients who had proteinuria after transplant have a lower graft survival and patient survival. So we pay attention to that too. And acute rejection, transplant glomerulopathy, or recurrent glomerular disease, or de novo glomerular disease can all lead to proteinuria in the allograft. Okay, you can go through 24-year-old woman with lupus, had a kidney transplant 4 months ago, and now come in with low-grade fever, had decreased appetite, and has nausea. Creatinine is 1.3 from a nadir of 0.8. UA showed 3 to 5 white cells, 3 to 5 red cells, and a little bit of protein. Ultrasound showed recessive indices of 85 to 90%, which typically this indicated there's kind of like intrinsic problem going on. Patent renal artery and veins, and this myopelviectasis. She has not been seen, this is again 4 months, has not been seen in the clinic or had labs done for 2 months. And she's admitted to the hospital, continuing on her home medications. Tacro trough was drawn, and it was only 4. Urine culture is negative, allograft biopsies is scheduled. So acute kidney injury in kidney transplant recipients. Again, if you, I just didn't put it in a way that we normally talk about in other patients, right? When you consult us, it's pre-renal, renal, post-renal, same thing. So decreased kidney perfusion, pre-renal, obstructions, post-renal, and intrinsic is like renal. So we go through the same thing, and typically rejection is kind of like lower on the, on the list, the further out from the kidney transplant. So volume depletion, patient might come in with a history of poor intake or having diarrhea. Of course, you examine the patient, look at the electrolytes. Renal artery stenosis, typically they have uncontrolled hypertension, and we would do an ultrasound with the Doppler studies. If you think of CNI toxicities, like the pictures that I've shown you guys now, you probably have it stuck in your head now, hopefully. We checked, we suspect that they have too much tacrolimus, then you check the level, you'll see that evidence. Obstruction, the patient can have a ureteral stricture. Commonly, it may be seen along with the BK infection. And ultrasound would show that there is evidence of obstruction, bladder dysfunction. Sometimes, patients, diabetic patients might have neurogenic bladder. And keep in mind that a lot of patients had been on dialysis for years, right? And they did not make any urine. Then they get kidney transplant, and then they started making urine, but their bladder might not so when someone is not making urine, the bladder has just got down to about what they call the walnut size, and then they would just have to retrain the bladder all over again. So that we have to keep that in mind, that it might not reveal, or even the prostate, patient might have had a BPH and did not know because there was no urine when they were on dialysis. So this can become apparent after the kidney transplant. So ultrasound, of course, would tell you about the obstruction. Intrinsic kidney injury, cellular rejection, of course, we worried about in a kidney transplant. You would have to do the biopsy. Acute antibody-mediated rejection. There might have been so in these two, they usually there is history that either the patient stopped taking medications or maybe had a prior infection. We have to lower immunosuppression, and then that increased their risk of having a rejection. Drug toxicity, like we talked about, antibiotics, a calcium inhibitor toxicity, infection can be pyelonephritis, UTIs, or BK infection. Post-transplant lymphoma in the allograft, very rare, but can happen. And we would, if we think of that, we would send for the EBV viral load and allograft biopsy. A recurrent disease, the most that we talked about the most is FSGS, which is 30% chance of recurrence. Unless it's a familial FSGS, then the patient would not have recurrence. But minimal change IgA nephropathy, immune complex GN can have a recurrence in the kidney transplant, and we would have to do the allograft biopsies. So the patient that we looked at here is having most likely a rejection due to medication non-adherence, because this is only the 4 months, and already she was just no-show for labs for 2 months, which is very critical. The first few months, several months after the transplant is very critical. So fortunately, this lady had a kidney transplant rejection. You see the tacrolimus level is low. Sometimes the patients would fool us because after not taking the medications for 2 weeks, then they would take with Tacro the day before coming to the hospital or coming to the clinic. Then you check the level and it's like, well, the level is good, but the patient ended up having rejection. So when to reach out to call the transplant center, you can call right away, or when there's significant change in renal function, a new onset of proteinuria, a significant increase in the baseline proteinuria, and of course, when the patient have a failing allograft and you think they would need a retransplant evaluation. Okay, I'm gonna go really quick. Cardiovascular disease is the most common reason that we lose the kidney transplant patients. So as you know, that dialysis patients, right, have a higher risk of cardiovascular disease compared to general population, which is the red line here, hemodialysis screen. So kidney transplant significantly improved that, but still higher than general population. So they still has to we do have to take care of all these conditions. Traditional risk factors, like what we normally assess in non-kidney transplant patients, and there are non-traditional risk factors, including that a lot of these patients have been on dialysis, and dialysis does have the negative effect on cardiovascular health, rejection, and then other derangement that can add on as the other risk factors for cardiovascular disease. This just show that it's pretty worrisome that you would see that the ACE inhibitor, ARB, which we deem like a very beneficial for cardiovascular disease prevention, right, or management. This study showed that only less than half of the patient were on at the time of transplant, which is understandable. We don't like to use it initially because that can lead to elevated creatinine and make it confusing. But at 1 month post-transplant, only 12%. Then at 6 months, when you should be kind of out of this like early phase, should feel comfortable using it, but less than a quarter of the patients were on ACE or ARB when they should, and less of 30% of the patients with cardiovascular disease already or diabetes were on ACE inhibitor or ARB at 6 months after the transplant. So this just kind of like raised the concern that these patients, when they get the kidney transplant, ACE or ARB were stopped and basically were not restarted when they should be or should have been. And aspirin use is less than 40% of the patients, but we can talk about aspirin like separately, right, with the new guidelines. Hypertension, still the RAS blockade is a cornerstone of the antihypertensive management in CKD population. So we can use that too, but there had not been a significant evidence shown in the kidney transplant population. I'm just going to go through that. So strategies in treating hypertension in a kidney transplant, right? So there is no specific agent that one would say that use this, do not use that. But I'd like to use a calcium channel blocker that is the dihydropyridine group, which has a vasodilatory effect that might counteract with the vasoconstrictive effect of a calcineurin inhibitor. But again, I don't use the non-dihydropyridine type. And consider using the RAS inhibitors after initial 3 months, especially if the patient has proteinuria or have diabetes or pre-existing cardiovascular disease. And there's really no randomized control trial about what is the blood pressure goal, but generally it's recommended to keep it below 130/80. And sodium restriction still remains important because after the kidney transplant, the patient's happy and happy people eat, so you still have to advise the patient to maintain the diet that is heart and kidney healthy, and not going too crazy about the food. Post-transplant dyslipidemia, just know that majority of the patients after the transplant have a total cholesterol more than 200, and almost 100% have LDL more than 100. So we treat this dyslipidemia. There are multiple things that can add on in transplant patients to have even more trouble with the lipids. The studies show that statin has benefit in renal transplant patients, but only when they extended the follow-ups to roughly to 7 years. Original study at 5 years, they didn't see the significant difference, but follow 2 more years and they started to see the benefits. So we recommend the patients to be on statin therapy. And keep in mind, because I mentioned earlier, there's interaction with the calcineurin inhibitor. So we will start at the lower dose, like kind of half of what we would do with a non-transplant patient. And if they tolerate well, then you can titrate up and not necessarily have to stay at the low dose, and just advise them to monitor for things like myalgia and just be on alert that they can be more toxic than others because of the drug interaction. This one, I think that we probably out of time, right? So infection, I was just, so this is the questions that show the patient, come in with leukopenia and found that had a CMV of 30,000 copies, and biopsy even showed a CMV colitis. So the treatment for this patient would be, there are two options you can treat the CMV infection in transplant patient with either oral valsite or IV ganciclovir, but tissue invasive disease like this patient is the IV ganciclovir. So this like one slide capture it all. So I just wanted to show, and this is modified from New England Journal paper as well, on the timeline of post-transplant infections, that early on, could be related to surgery, like a common wound infection, post-op complication type, or donor-derived. If there's going to be any, it will show up pretty early after the transplant. Then the 1 to 6 months are common, very common for CMV infection and other things too, without prophylaxis. And then later on, you have to keep in mind that they can also have community-acquired infection, like community-acquired pneumonia or just a simple UTI, which is not so simple in a kidney transplant patient. And then other specific viral infection that can happen in kidney transplant patient, like BK nephropathy or skin cancer or PTLD, which is related to virus induced. I think malignancy, right, so the kidney transplant patients had approximately 3 times more likely to develop cancer than general populations. And risk factors is because of the immunosuppression and certain viral infection, and pre-transplant dialysis also increase their risk of having cancer. Skin cancer is number 1. Squamous cell cancer is most common malignancy in solid organ transplant. So if you guys don't remember any part of this slide, is this because this would be your board exam as well, and it's true for other solid organ transplant, right? So squamous cell cancer. And so we still do a cancer screening in the patient as we would do for general population. You have to refer them to see dermatologist once a year, or sometimes even more often than that, and the dermatologist would take a look at the whole body, doing total body skin examination. That's it to summarize, various aspects of possible complications and how we take care of a kidney transplant patient.